que darle en play a algo.
¿Ya podemos arrancar? Buenos días. Nos sentamos todos, por favor. Vamos a comenzar con el simposio. Buenos días, nos sentamos. Buenos días a todos. Muchas gracias a Pfizer por su amable invitación al simposio sobre desafíos en el diagnóstico de artritis psoriásica. Brevemente, la artritis psoriásica se presenta más o menos en un cuarto de los pacientes con la enfermedad psoriásica. Sin embargo, el diagnóstico muchas veces es difícil, particularmente en aquellos individuos en que el compromiso articular antecede al compromiso cutáneo. Por eso tenemos a los expertos, al doctor Vinod Chandran y al doctor Bautista, que nos hablarán al respecto y qué estrategias se deben tomar para hacer un diagnóstico precoz con el fin de evitar el daño articular, una peor calidad de vida de estos pacientes y comorbilidades. Y de pronto tocar algún tema de biomarcadores para el diagnóstico, puesto que es importante considerar cuáles biomarcadores están en curso para el diagnóstico temprano de estos pacientes que van a desarrollar artritis en el marco de la enfermedad psoriásica. De hecho, se dice que alrededor de hasta un 15% de los pacientes que están en una clínica de dermatología con psoriasis no tienen tienen artritis, pero no se les ha diagnosticado. Así que tenemos en el programa al doctor Bautista, iniciará con epidemiología y panorama de la artritis psoriásica en Colombia, y posteriormente tenemos al doctor Vinod Chandran con desafíos en el diagnóstico clínico de la artritis psoriásica. El doctor Bautista es médico internista y reumatólogo, profesor asociado de la Universidad Militar Nueva Granada y profesor del Hospital Universitario Fundación Santa Fe. Por otra parte, tenemos la grata visita de tener aquí al experto, el doctor Vinod Chandran, quien es médico especialista en reumatología de la University Health Network, Toronto, Canadá, es profesor asociado de la Universidad de Toronto y PhD en epidemiología genética. Iniciaremos entonces esta sesión, este simposio, con el doctor Bautista sobre epidemiología y panorama de la artritis psoriásica en Colombia. Muchas gracias de nuevo a Pfizer por su amable invitación.
Bueno, muy buenos días, estimados colegas. Muchas gracias, Luis Alfonso, por la presentación y, por supuesto, un agradecimiento a Pfizer por la invitación de poder compartir con ustedes, estimados colegas, un tema que representa para mí de gran interés y de gran pasión, que es el abordaje de la artritis psoriásica. Y mucho más interesante en este simposio cuando vamos a tener la opinión de un colega internacional de un centro de referencia en artritis psoriásica que seguro va a aclarar muchas de nuestras inquietudes, de nuestras dudas, y nos va a permitir conocer más en detalle el adecuado enfoque de estos pacientes, conociendo que esta es una enfermedad no solo multidominio, sino que tiene una presentación clínica muy heterogénea. Entonces, en estos minutos, colegas, voy a presentar cuál es el panorama actual que nos encontramos a nivel país de lo que conocemos en relación con artritis psoriásica. ¿Qué hemos avanzado? ¿Qué datos podemos decir de nuestra población? Y lo más importante, ¿cuáles son esos retos? ¿Cuáles son esos desafíos que nos esperan a nosotros como reumatólogos para conocer más en detalle la enfermedad y, sobre todo, poder aportar soluciones en el contexto de la enfermedad? Estos son mis conflictos de interés y quiero iniciar presentando el contexto, el análisis situacional de la enfermedad en nuestro país. Vemos que en los últimos años disponemos de varios estudios que nos permiten conocer un panorama no solamente a nivel nacional, sino también local, vamos a hablar de ellos, y tenemos datos respecto a la prevalencia. Un dato muy importante desde el punto de vista epidemiológico que nos permite evaluar y, sobre todo, tomar decisiones a nivel del desarrollo de estudios prospectivos, estudios longitudinales, y vemos cómo cobra importancia tener esos datos no solamente a nivel nacional, sino también a nivel regional. Hemos estimado también la prevalencia en nuestro país, tanto en pacientes con espondiloartritis como en pacientes, en individuos sanos o controles, que es algo que había sido esquivo hasta hace algunos años. Y hay un interés muy importante, estimados colegas, de conocer el comportamiento de la enfermedad en nuestra población. Sabemos que se comporta diferente cuando hablamos de poblaciones mestizas. Y es ese background genético el que no solamente nos habla de la baja prevalencia del B27 en nuestra población, sino muy probablemente, colegas, de un patrón diferencial de presentación de la enfermedad y muy probablemente respuesta diferencial también al tratamiento, que es algo que en los próximos años debemos evaluarlo en nuestra población. Sin embargo, hay ausencia de información de la carga en artritis psoriásica. Son muy escasos los datos que nos dicen cuánto es el impacto en el sistema de salud, en costos, en calidad de vida, en deterioro funcional, y algo también que es necesario, que es el perfil de tratamiento, que todavía no lo conocemos en detalle. Pero por supuesto, esto está en marcha, hay esfuerzos en marcha y hay varios trabajos actualmente en curso que nos permitirán conocer esta situación. Respecto a datos del país, parto de este estudio de prevalencia muy bien conocido por todos nosotros, que fue la estrategia COP-CORD, que evaluó en diferentes regiones a nivel país toda la prevalencia de enfermedades musculoesqueléticas, incluida en este caso espondiloartritis. Y vemos aquí las diferentes tasas de prevalencia que mostraron los resultados en este estudio, en el que desafortunadamente no se identificaron pacientes con artritis psoriásica. Y pues no vamos a hablar en detalle de la metodología, pero digamos es algo muy interesante para explorar en un futuro la presencia en este tipo de estudios y en esta metodología COP-CORD. Probablemente, y es una opinión aquí personal, muchos de estos pacientes que aquí los definimos como formas indiferenciadas de artritis y de espondiloartritis, probablemente sean pacientes que tengan un diagnóstico, una artritis psoriásica, probablemente sin un compromiso cutáneo claramente manifiesto. También tenemos datos, estos datos del grupo de la Javeriana, de Daniel, donde evaluaban las prevalencia y las características demográficas en artritis psoriásica, y es un abordaje inicial de evaluar datos de bases de datos administrativas para conocer los registros que nosotros manejamos en el día a día y que manejan las entidades gubernamentales para conocer de forma indirecta la prevalencia. Y es así como en mayores de 20 años se habla de una prevalencia de 13.5 casos de artritis psoriásica por cada 100.000 habitantes, con una relación mujer-hombre de 1.2. Entonces este es uno de los primeros abordajes, colegas, que nos hablan de ese escenario de prevalencia en el contexto nacional, partiendo de esos datos administrativos. ¿Qué otros datos tenemos? Estos también son datos de una cohorte de pacientes, de más de 500 pacientes con espondiloartritis, donde vemos cómo en esa cohorte se identificaron solamente 21 pacientes, un porcentaje muy bajo, que nos representa, esta foto nos muestra, colegas, la foto probablemente del subdiagnóstico que tenemos en identificar esos pacientes con artropatía psoriásica en el contexto de pacientes con espondiloartritis, donde uno esperaría en las cohortes internacionales y otras realizadas por colegas en América Latina, como en Argentina, por ejemplo, donde esa frecuencia de artritis psoriásica en el espectro de espondiloartritis es alrededor del 20%. Entonces aquí vemos que hay esfuerzos que debemos realizar en nuestro escenario nacional para poder llenar estos vacíos de conocimiento. También conocemos cómo la ancestría desde el punto de vista B27 en población sana nos refuerza que en varias regiones del país, especialmente en la región andina, pues hay una influencia caucásica muy fuerte, y por supuesto necesitamos validar estos estudios en poblaciones originarias y también en poblaciones afrocolombianas. Avances también, ya disponemos de recomendaciones de tratamiento. Vemos aquí la recientemente publicada de espondiloartritis periférica, donde se habla del manejo de pacientes con artritis psoriásica y que constituye esa iniciativa a nivel nacional de tener lineamientos terapéuticos para homogeneizar este tipo de conductas. Y ya para terminar, esta es mi última diapositiva antes de darle la palabra al doctor Vinod Chandran. Retos y oportunidades que nos esperan son múltiples. Pienso personalmente que los estudios observacionales de los diferentes subtipos de espondiloartritis, enfocados también en artritis psoriásica, nos permitirán conocer muchos más detalles de la enfermedad. Información que necesitamos en población afro, colombiana y originaria en relación con la prevalencia del B27 y todo el espectro de manifestaciones extraarticulares, no solamente la psoriasis, sino también uveitis y enfermedad inflamatoria intestinal. Conocer los fenotipos por género, cómo se presenta la enfermedad en nuestro contexto, por hombres, por mujeres, y algo muy interesante que se ha hecho en otras enfermedades crónicas en América Latina. ¿Cuál es esa forma de presentación en población urbana versus población rural, teniendo en cuenta las diferencias de acceso a diagnóstico y tratamiento? Retos en cuanto a acceso, también en cuanto a la adherencia, y finalmente, estudios que nos permitan estimar la carga de la enfermedad y los costos son, digamos, aproximaciones que nos permitirán conocer más en detalle. Ya con esto, entonces, termino aquí mi presentación para poder darle la palabra al doctor Vinod Chandran.
A continuación está el doctor Vinod Chandran, que nos va a disertar sobre desafíos en el diagnóstico clínico de la artritis psoriásica. Doctor Chandran, bienvenido.
Thank you so much, I'm sorry I'm speaking in English, which, by the way, is not my native language. I come from the south of India, and my language is Malayalam, which is quite different. So I'm speaking a second language, and hopefully, yeah, the mic is okay. Yeah, perfect. And so I must begin by acknowledging the language. So hopefully we can communicate. What I'm tasked with doing today is to talk about challenges in the clinical diagnosis of psoriatic arthritis. And I must also thank Pfizer and the Colombian Rheumatology Association for giving me this opportunity to come to this beautiful country and place. So these are my disclosures. So the learning objectives for this short lecture would be to discuss the clinical heterogeneity of psoriatic arthritis and what the challenges are in making a diagnosis, and hopefully some possible solutions. So this is my outline. I'll talk about psoriatic arthritis. We'll talk about the assessment of the heterogeneous manifestations and challenges in making a diagnosis and possible solutions. So beginning with what is psoriatic arthritis, it's been described as an inflammatory arthritis associated, quote unquote, associated with psoriasis. So not everybody has psoriasis, but most patients either have it to begin with, 85–90%, or some get it after the onset of arthritis. And some, there are truly patients who don't have arthritis, but they have a family member with, so they have arthritis, but no psoriasis. They might have a family member with it. To differentiate from rheumatoid arthritis, because most of the manifestations are peripheral, it's typically seronegative. But that does not mean that there could be seropositivity. And it's one of the spondyloarthritis, and is classified by the Caspar criteria. So what I'll do now is to go through a few cases illustrating the heterogeneity. And these are patients from my clinic in Toronto. The first one is, and I came to Toronto from India in 2004. And many of you might know we have a longitudinal cohort there. So we see patients every 6 months, how well or bad they're doing. And we document the manifestations over time. We have a biobank. So there's a large database that has been collected over time by Professor Gladman, who's my mentor. And so these cases are from our cohort. The first one is a relatively young man, 35-year-old, who first came to a clinic in 2003. He lives inside, within the city of Toronto, and was initially diagnosed with having psoriasis 7 years ago. It was mild. He complained of recurrent joint pain, mainly in the knees and some hand joint pain. When we first saw him, he had psoriasis mild on the elbows and knees. He had nail lesions, and there was a number of swollen joints in his hands with DIP involvement, and then a knee effusion. He was treated with methotrexate, 20 milligrams weekly. This is going back to 2003, 2004. And even now, we start with methotrexate when there is peripheral arthritis. And then the methotrexate helped. The skin cleared. Joints were less painful. But whenever he came, there were a few swollen joints all the time, one or two, and there was no enthesitis or dactylitis. He also required knee joint injections for flare of his knee arthritis, and it's usually associated with some minor trauma, like physical exercise in the gym and stuff like that. So, grumbling disease over time. And that particular case, I think, from a diagnostic point, was straightforward. There was psoriasis, there was inflammatory arthritis with swollen joints, swollen knee, seronegative, he had nail lesions, and so it was typical. And I can come back to the case on what happened in our panel discussion. The second case was a little more tricky. She lived about 5 hours from the city of Toronto, so seeing a rheumatologist was not that easy. She had a history of mild psoriasis, which began in age 32. She had joint pain since age 40. And she was seeing her family physician quite often. She had pain while walking. She had hip pain and knee pain. And by 2007, she required knee joint, total knee replacement in one knee followed by the other. She's only given anti-inflammatories because investigations showed that the CRP, ESR was normal, rheumatoid factor was negative. So I don't know in primary care over here, but usually in Canada, when people go to joint pain to the primary care, they do ESR, rheumatoid factor, ANA, and if all three have negative, they generally tell them, oh, this is osteoarthritis or just mechanical pain, don't worry about it. Which is a problem for us because many of our patients are negative for all this and we need a proper physical exam. Primary care is not very confident in doing musculoskeletal examination, especially when the problems are in the feet. It is a difficult joint to assess. She had no problems in the upper extremities. And finally, she came to a clinic, and when we examined her, she had significant psoriasis. She had no psoriasis, but nail lesions, and she had tender joints and swollen joints, mostly in the feet. Hands, upper limbs were fine. And as you can see, her HAC was 1.88, pain score was 80, so quite a lot of pain and quite a lot of functional limitation. And when we do on every patient that we see, irrespective of the symptoms, we get spinal x-rays done, hand and feet x-rays done. And what we saw in those x-rays was that she had significant mid-tarsal joint disease. She had destructive hip arthritis, more or right on the left. And as I mentioned earlier, her knees were already replaced. So she had advanced arthritis primarily because no diagnosis was made. And nobody thought about psoriatic arthritis. And again, I can come back to the case later. The third case is even more interesting. This guy was never diagnosed with psoriatic arthritis, and we can have a discussion if they indeed have psoriatic arthritis. He was a 40-year-old male. He lived just outside Toronto. He had severe psoriasis, but never reported any joint pain. And then for his psoriasis, he was seeing a dermatologist. He was treated with topical steroids and methotrexate without much of relief. And finally, he was treated with ustekinumab. This is going back to 2015. And 6 months later, he told his dermatologist, I don't have joint pain. But then the dermatologist said, but you never complained of joint pain in the beginning, to begin with. So then he was referred to me because he's, what's going on? So when I talked to him, he said, well, people have talked about joint pain. And by the way, he was working for one of the pharmaceutical companies, so he knew very well about psoriatic arthritis. But he never thought he had that. He had significant psoriasis. He was treated with an effective therapy. And then he realized that he has no problem getting up in the morning, going down the steps, from his bedroom to the ground floor, and there was no heel pain and feet pain. That's when he realized that he actually had joint pain, which now is better. And previously, he didn't recognize that. And these are not from him, but what we are seeing in that phenomenon is enthesitis. And nowadays, with better understanding of enthesitis, with imaging like MRI and ultrasound, these are from my colleagues, these pictures, you can see how the diagnosis can be made. And this patient had no swollen joints. It was predominantly enthesitis, which got better with treatment with a drug like ustekinumab. And those are the pictures there. And the final case is again talking about the heterogeneity here. It was a 50-year-old male. We have a program where we ask patients with psoriasis who do not have psoriatic arthritis to come to a clinic to take part in a longitudinal cohort. So we see them every year, get their blood samples, DNA samples, and follow them up over time to see if they develop psoriatic arthritis, with the idea that we can identify predictors for psoriatic arthritis. So he said, I saw your flyer, I'm interested in participating in this study, let me take part. So when he examined him, he complained of some back pain, but not very non-specific. It was not inflammatory. He had moderate to severe psoriasis. And when he examined the spinal mobility, there was some restriction, but nothing significant. But when we did X-rays, because of some back pain and restricted mobility, he had bilateral grade 2 sacroiliitis. So the question is, does he have psoriatic arthritis? We went further and confirmed that yes, he has sacroiliitis, but it was not symptomatic. So this is another manifestation. And so when Wilson was talking about the prevalence of psoriatic arthritis in Colombia, my thought was that there are a lot of patients who are undiagnosed, and so they may not be captured. So for example, when you do surveys of psoriasis patients and examine them carefully, the prevalence is about 25%. For example, in Canada, the prevalence of psoriasis is 3%. So you expect about 1%, 0.75 to 1% of the population to have psoriatic arthritis. But when we do population-based surveys, it's much less. So either we are, so the exact estimate of how much psoriatic arthritis is there is difficult because the diagnosis, there are no biomarkers, X-rays may be normal, and so we have to get that message out there to the primary care, to dermatology, that please look carefully and then refer if you think there is a problem. So a lot of diagnostic challenges. And this is just to illustrate that psoriatic arthritis is in the spectrum of spondyloarthritis. And so when you think about the disease, we have to think about spondyloarthritis in general and specifically psoriatic arthritis. And this just is to illustrate that for studies, we use the CASPAR classification criteria to classify them, but these are not diagnostic criteria. And I'm sure you're aware of these criteria. So how do you assess these heterogeneous features? Many of our rheumatologists are also find it difficult to assess a patient with spondyloarthritis and especially psoriatic arthritis. So the problem is, as I was mentioning, the heterogeneity. The skin disease itself is very heterogeneous. There is chronic plaque, the vulgaris, which is on the external aspects. Then there is a flexural psoriasis, so under the breasts or in the axilla or natal cleft, places where, as a rheumatologist, you might not examine carefully. There is pustular psoriasis. The nail psoriasis is also quite difficult to assess. And then the arthritis itself is heterogeneous. You have any joint could be affected, both from the axial or peripheral domains. So we have to look carefully. Sometimes sacroiliitis is not there, but spinal disease is there. So assessment of the disease takes more time and needs to be more comprehensive. There is dactylitis, there is enthesitis, and then if you don't recognize it early, there can be severe destructive arthritis, right? So it's difficult to assess all that. And on top of it, they might have uveitis or inflammatory bowel disease. And so assessing all these domains becomes challenging. And what we recommend from GRAPPA, which is the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, which Wilson is also a member of, we say, okay, let's bring down these manifestations into 6 domains. So let's look at the skin by yourself or the help of the dermatologist, the nail disease, peripheral arthritis, axial arthritis, enthesitis, and dactylitis. So we look at these separate domains, and in your clinical notes, we always mention how active these domains, is it involved, and how active it is. And the peripheral arthritis can be quite heterogeneous. It could be just a few joints. It could be polyarthritis. Typically, the distal interphalangeal joint involvement is characteristic, and sometimes it can lead to very destructive arthritis mutilans. And one of the typical manifestations is this redness around the joint. So it looks, because inflammation is actually in the capsule and enthesis, so the skin gets inflamed, and that's where the joints look redder compared to rheumatoid arthritis. But of course, that leads, sometimes if it is really red, then you also worry about infection. And then gout is another problem that we need to assess. As a rheumatologist, this is common to us. When you have peripheral arthritis, you got to differentiate from osteoarthritis, rheumatoid arthritis, gout, and psoriatic arthritis. And there are features of all of this which you can review, but I'm sure all of you are aware of how to make this differential diagnosis. But it's always good to think about these manifestations. Enthesitis is more tricky. I mentioned that case where he had feet pain, heel pain that got better with treatment. The trouble, as there is always enthesopathy when one gets older or heavier. And generally speaking, psoriasis patients are more obese than the general population, so a lot more enthesopathy. The question is that enthesitis or enthesopathy? And that's always not very easy to diagnose. And we need imaging like of pictures that I previously showed to help make that diagnosis. And many times it's tricky, especially if enthesitis is the main manifestation. Dactylitis is relatively easy to diagnose because the fingers or toes are swollen. And of course, there are differential diagnoses: infection, gout, tuberculosis, all that should be carefully ruled out. But in general, if there is psoriasis and dactylitis, it's most likely psoriatic arthritis. And the imaging shows inflammation in the tendon sheath, the soft tissue, the bone, everything is inflamed in the finger or toe. And axial arthritis is also tricky. Generally, patients have less pain compared to ankylosing spondylitis, and it's less severe, but it could be very severe too. So there is a lot of research now trying to figure out how different it is from ankylosing spondylitis or axial spondyloarthritis versus psoriatic spondylitis. Are they similar? Are they very different? And there is an ongoing study from GRAPPA called AXIS study that will help us make that differential diagnosis. And then psoriasis, we need to carefully examine, like I mentioned. There are many types of psoriasis. And one other thing is that the psoriasis looks different based on the color of skin. So most of the textbooks that, at least in North America and India, we look at are not directly based on patients that you see. So it's very important to look at the skin color to figure out if it is. So it may not look like what you see in the textbooks. And now people are developing textbooks to look at psoriasis in the more darker skin population. And then extraskeletal manifestation or extra musculoskeletal manifestations are many, like I mentioned earlier. So carefully looking for that is also important. And you might need help from your colleagues in dermatology, ophthalmology, gastroenterology to evaluate whether the symptoms are non-specific or actually there is inflammatory disease. And so how do we move forward? What are the challenges? Are there any solutions? So to make a diagnosis, the important thing is to convince yourself as well as the patient that it's actually an inflammatory arthritis and not non-specific or non-inflammatory arthritis like osteoarthritis or fibromyalgia or enthesopathy. And then once you're convinced that it's inflamed, you have to look for typical patterns. So if it is peripheral arthritis, there is less symmetry in psoriatic arthritis compared to rheumatoid arthritis. Typically, early disease, you have oligoarthritis disease, so 4 or less joints. and it's asymmetric. You can have ray distribution of involvement. So ray means like dactylitis, right? So in rheumatoid, you have more MCP involvement, so it's a row pattern, whereas in psoriatic, it's in this direction. So MCP, PIP, DIP, so more like a ray rather than a row pattern. And then inflamed DIP joints are very typical. The differential diagnosis, of course, you have to think of osteoarthritis and gout and sometimes JIA. Axial arthritis, if there is axial arthritis is present, even if it is asymptomatic, that's why I always get at least an X-ray of the spine of the pelvis for sacroiliitis, and if that is present, then it gives you an additional, at least tells you that this patient has spondyloarthritis, and then because of psoriasis, it is psoriatic, you can call it psoriatic arthritis, and recognize dactylitis and enthesitis. Most of the time, the psoriasis is easy to diagnose, and if you're sensitive to it, but it could be absent, and so that becomes challenging if you have very typical psoriatic pattern without any psoriasis. But then look for family history to help you out. Nail psoriasis is also important. If you have psoriasis and nail disease, it's more likely you have psoriatic arthritis. But of course, sometimes nail disease is hard to distinguish from fungal disease, fungal nail involvement, especially in the toes. So we only generally examine the fingernails rather than the toenails because toenails are always hard. And then you go and do your laboratory investigations. Rheumatoid factor is usually negative, but it could be positive. If it is positive, low titer, it does not negate the diagnosis of psoriatic arthritis. CRP, ESR is usually, at least in where I come from, it's only mildly elevated or normal. So it's hard to see people with very high inflammatory markers. And that's why many of the diagnosis is missed. And then HLA-B27, it's about 15-20%, so not strongly positive. Imaging is key. So you always get X-rays for the hands, feet, and pelvis, and cervical spine, just to look for these features. And then depending on other symptoms, you may want to do ultrasounds or MRIs to really understand what is going on in the joint and to differentiate it from mechanical issues. The biggest challenge is that the symptoms could be from ordinary back pain or enthesial pain or osteoarthritis. And so to convince yourself that there is enough inflammation to call it an inflammatory arthritis. Think about the other inflammatory arthritis, RA, other SPA, gout, common, especially because our patients are older and they have metabolic syndrome. So many patients have overlapping gout, which sometimes become a problem. Occasionally, with other connective tissue diseases, you might have a problem. Lupus patients can have a psoriasiform rash, and it can be a problem sometimes. And then the biggest problem, in my opinion, would be osteoarthritis and mechanical enthesopathy, DISH, and fibromyalgia. So we have written a paper, the references over there, to try to how to distinguish between these manifestations. And the challenges are because, like I mentioned, there is non-specific back and joint involvement, less awareness among dermatologists. But it is better now, but still we need to put the message out. But mainly about primary care and internists. The manifestations subtle, especially in early disease. No biomarkers, and the inflammatory markers are normal, and the big overlap with osteoarthritis. And what are the solutions? One thing is to get the awareness, get patients to be seen in psoriasis clinics, or if there is a family history. If there is joint pain, evaluate them carefully. You can use screening questionnaires, and then to make the diagnosis. But the biggest the challenges would be in meetings like this to get the message out to not just us, but the primary care and dermatologists. Get combined clinics could be useful where you can work with dermatology to look at arthritis. Training in ultrasound and MRI to really understand the inflammation in these joints, because it's very different from rheumatoid arthritis and gout and other differential diagnosis. So imaging does make helps you diagnose it very well. And then hopefully in the future, a diagnostic test would help. So with that, I'll stop. We went through these outline about the arthritis and the heterogeneous manifestations and the challenges. And to summarize, PSA is a heterogeneous disease. It's problem is the similarity with mechanical enthesopathy, back pain, and osteoarthritis. Not so much with other inflammatory arthritis like rheumatoid arthritis. The lack of biomarkers, and the solutions are more from an educational viewpoint rather than from a clinical viewpoint. And so spreading the awareness, training rheumatologists and imaging radiologists about PSA and the degree of, and how to diagnose it based on the imaging when the diagnosis is not clinically clear, and hopefully developing a diagnostic test, which, by the way, I'm spending quite a lot of time on. With that, we can go to the panel discussion, and hopefully we are on time. Should I go through the cases and then the same cases we can discuss it again? Okay. I put it in a thing. Yeah, that will be workable. And we can ask. We have time, right? Okay. Yeah.
So do you need to put the cases?
It's there.
Okay.
That's great. So we want this to be interactive, and I'd like to get your opinion on some of the things that I mentioned. And I thought the way to go forward on that would be to go back to the 4 cases that I showed. And maybe you can comment, Wilson and anybody else who's interested on what do you think about the case and what would you have done similarly or differently. So the first case, just to remind everybody, was a rather typical case in my opinion. Had psoriasis, had polyarthritis. Psoriasis was not a big problem. He had hand joint pain and knee joint pain. He was treated with methotrexate, 20 milligram weekly. And he was on that drug for almost 10 years. With that, the skin cleared, and the joints felt better, but there was always this grumbling disease, 1 or 2 joints involved. And as I said, we see patients every 6 months. We do a joint count. We do x-rays every 2 years. So we've been kind of following. And then his biggest challenge was that he would go to the gym, lift something, and his knee would swell up, and he would stop. We'd come back, inject the joints. And he needed an injection once a year, maybe once every 2 years. So not too bad, but still a problem. He was afraid of exercising because of that. So this was the first x-ray when he first came. It looked pretty good to me. And over the years, what happened, I'm just clicking here because I know it's hard to see. The resolution is not good. But if you look very carefully, all these arrows that I've pointed are erosions that he had. DIP joints, MCP joints. And this was on methotrexate. So, Wilson, can you begin talking about this case? What was, give a mic. And anybody else, please feel free to talk about this.
Okay, thank you, Vinod. Si alguien tiene alguna pregunta en relación con el caso, como lo veníamos comentando, pueden hacer las preguntas en español y hacemos la traducción. I would like to comment on this case, really very, very interesting, and also to put our stress about the importance of imaging. So in this case, as we saw in the slide, there are slight changes that we have to consider. Sometimes for radiologists, often is lesion forgotten. So we can miss the case and make a sub-diagnosis of psoriatic arthritis. So I think this is my comment, and also to put the importance of X-radiography.
Yeah, so the erosions are very subtle, and sometimes the radiologists, if they're not very tuned to it, don't give you a detailed report. So we read the X-rays ourselves and score it. And when the manifestations are slow over time, we don't give much of, we might not take it very seriously. But when you compare, if you have serial X-rays and you compare 2003 to 2012 and you see a big difference, then you realize, oh, although we thought he was doing okay, actually not doing very well. And if with continuing methotrexate, he might have continuing joint damage. And once there is joint damage, there is more damage that accumulates. So there were grade 2 erosions in 11 hand joints. And what we did, we switched to etanercept. This is going back to 2012. And following that, he felt really good. He no longer had the knee joint effusions that was causing him a problem every few months. And his hand joints are all looking very good. And he's continued to do well for quite a long time. In the audience, if there is somebody who wants to come in, that'll be great. My question is, in Canada, it's a little tricky because you cannot, although the guidelines say methotrexate, if it doesn't failure, then you can go on to a biologic. The insurance companies in Canada, including the Ministry of Health, requires that you fail 2 drugs. So we could manage to go to etanercept in him, but ideally I would have, nowadays we would have to put him on leflunomide or sulfasalazine, show that it's not better, and then switch him. The other problem, of course, is they don't care about progressive erosions. They just say, oh, you have to have 5 swollen joints. So if you have 1 or 2 swollen joints, you never reach that criteria for getting access to the drug. How is the situation over here? Is it similar, or it depends on how much money and other things?
Tricky question, Vinod. In general, the situation is similar. We have to rely on clinical examination, number of swollen joints, number of painful joints, and also the imaging is almost required. So we have to have at least 1 imaging in order to decide treatment, and also is frequently to start for methotrexate. Also leflunomide as second option, and sulfasalazine as a third option. And sometimes, really, in the country, we use a combination treatment between these 3 drugs.
Okay.
We used to start treatment with methotrexate, but my question, probably sometimes sulfasalazine because it start working later. So another option would be leflunomide before starting on those patients with severe forms of psoriatic arthritis. So we used to wait about 3 months to decide a change to a biologic therapy and start with anti-TNF therapy, for example, in these patients.
Yeah. So our place also, we need an imaging, like you said, evidence. But in addition to imaging, you have to fail 2 drugs with adequate therapy. So at least 3 months with 1 drug, so at least 6 months. And also with 5 swollen joints, right? So it's, if you have 2 to 3 joints, even if you have progressive imaging changes, it would not be sufficient. But so it's always similar problems everywhere. Although we have great drugs, sometimes accessing that might be a problem because of the rules. So the second case is the woman I mentioned who was not diagnosed, who had knee joint replacements pretty soon, then hip joint replacement, but did not have upper limb involvement. And as I showed earlier, the changes were in the mid-tarsal joints and the hip joints, which was missed completely. What we did after we diagnosed her, because she had already had severe destructive arthritis, we gave a short course of methotrexate, which did not help, and leflunomide, and then started etanercept, with which she had great improvement. But then a few years later, had secondary failure, more swollen joints. Then we switched to adalimumab with methotrexate. And after that, she's been doing very well. But her HAQ score and pain score has not really improved. So she recognizes that things are better, but from a function and pain, because of the joint damage, it's not very good. So this illustrates that the delay in diagnosis, when her manifestations could have been picked up earlier by a proper physical exam, is a problem. There is a tendency in Canada to not examine the lower legs because RA, it's ACR 28 joint count. So you do hands and knee and you're saying, oh, you're fine. Nobody examines the hip or the feet very well. The other problem is lack of time, so they don't look for skin psoriasis very carefully. And so the skin rash is missed, the joints are missed, and that leads to delayed diagnosis. So in a heterogeneous disease, you need to spend a little more time. I think an exam of psoriatic arthritis and other spondyloarthritis takes a little longer than rheumatoid. And so we got to train the next generation of rheumatologists that got to really spend a little more time in spondyloarthritis, otherwise you're going to miss the diagnosis. Any comments? Anybody?
I guess it's important what you say. We have to examine lower limbs, especially the feet.
Yes.
Sometimes, and also for all of the fellows and rheumatology training, we have to look carefully, looking not only for arthritis, but also dactylitis, that is more common. It's my impression, and also what we see in the literature, that more than 60% of dactylitis is on feet. I don't know if it's the same impression for you, Vinod.
Yeah, and for some reason, the fourth toe is the most common site. I distinctly remember seeing a patient in the psoriasis clinic. I had a combined clinic, and everybody's in a hurry. And in psoriasis clinics, they spend 5 minutes with the patient, right? Yeah, skin treatment next. And the patient is also in a hurry. So I said, do you have any problem? No. I said, remove your shoes. They said, no, I don't have time. But I insisted, and there was a dactylitic toe. And then when I asked them, what is this? They said, oh, I must have hit somewhere. Everybody attributes it to some minor trauma or injury, but that was clearly dactylitis. And so if the shoe was not removed and somebody had not examined it, the diagnosis would not have been made. So a good physical exam, of course, is the first step to making a diagnosis, history and physical exam.
Dr. Chandran, sorry. For early detection of another domains of psoriasis, for example, dactylitis, enthesitis, I believe that it's very important to have the role of ultrasound now.
Yes.
For an early diagnosis in those patients who are complaining about pain, but you on the physical examination do not detect the presence of this manifestation. Yeah. But probably ultrasound help us to detect in an early.
Yeah. And that's a good segue to the third case that I mentioned, who even the patient did not realize that he's having joint pain, right? It's only after he got a biologic, in this case it was ustekinumab, and the skin got better, he realized that, the difficulties that he was having in the morning, going up and down the stairs, heel pain, he was saying that he used to get up in the morning, go stiff to the, he had to sit on the stairs and slide down. This is 6 o'clock in the morning. By 7 o'clock, he was fine. And he never thought that he is actually having enthesitis. And if you go to a psoriasis clinic, there are a lot of patients with this. And with the dermatologist will tell you, talk to your dermatology colleagues, that so many patients, after they put down a biologic for psoriasis, come back to say, oh, now I don't have joint pain, when they actually didn't know that they had it before. Especially in the feet, the common sites for enthesitis is the back of the Achilles insertion, plantar fascia, and the lateral epicondyle. So those are the areas that you can ask about pain and examine. And like you mentioned, I don't have it here, but the ultrasound, like I showed you before, right? The MRIs and ultrasounds are very much more better than physical exam and even X-rays to identify inflammatory disease, because X-rays will show you bone proliferation and occasionally erosions. Erosions are rare, but bone proliferation. But you tend to have bone spurs in the Achilles and the plantar fascia as you get older. So, and especially if you're obese. So, how do you make that distinction? Whereas imaging, ultrasound, and MRIs can pick up the degree of inflammation, but it's still a work in progress. There is a lot of research going on to understand this better and then make a module for the radiologists as well as rheumatologists to describe it better. It's not easy, and sometimes we do therapeutic trials to see if the inflammatory arthritis, the enthesitis gets better or not. And finally, the question was about axial disease. This patient didn't really complain. He had some restriction of mobility, His psoriasis was a bigger problem. And when X-rays showed sacroiliitis. Any comments? Does he have psoriatic arthritis? How would you treat it?
I like this picture. Really, this is the forgotten domain in psoriatic disease. And also, as you can see in the picture, at the lower part of sacroiliac joints, you can see some findings that are highly suggestive of sacroiliitis. So my question here is, Vinod, how do you assess axial involvement clinically in patients with psoriatic arthritis, not depending only on symptoms of back pain? What could be your suggestion?
So I published a couple of 2-3 years ago about back pain in psoriatic arthritis, and the classic inflammatory back pain criteria that was developed for axial spondyloarthritis did not seem to work very well for psoriatic arthritis. So primarily because they're older and heavier, and many patients have asymptomatic back involvement. And so what that study showed was that we need to focus more on imaging to understand it better. So we always get pelvis X-rays on our patients, even if they don't complain of back pain, number one. But if they have back pain, yes, we do it. And then if there is X-ray changes, because as you know, the reliability of X-rays are a problem, we are most often, or especially if if the X-rays symptoms of back pain, X-ray normal, we do an MRI. If X-rays are abnormal, but patient has no symptoms, again, we would like to understand it better to see whether it's, recently we had a case which looked like exactly like this, but then he had a CT done for an abdominal problem, and in the CT we could see that the capsule was calcified, and so it was more capsular calcification. He had some other calcification, so more dish-like, and he did not actually have sacroiliitis. So imaging is really key. And of course, if there is not significant pain, we don't treat it specifically, but we always rely a lot on imaging to then, at least we know that this domain is involved. It's important because patients with sacroiliitis and back involvement are more likely to have very severe peripheral arthritis and more damage. So we have to take that into account.
Okay, thank you.
I think this
I have a question. Si nos un micrófono, por favor.
Hello, thank you. I would like to ask you, Dr. Chandran, at the table, if the presence of any erosion or any radiographical sign of progression is a motive to change treatment from conventional DMARD to biological therapy, or to move forward to another biological or JAK inhibitor. Thanks.
Yes, that's what we were talking about. From a medical point of view, if you see progressive erosion on leflunomide or methotrexate, yes, we need to change therapy. Sometimes we land into trouble because the insurance and criteria for access say that you should have 5 swollen joints, for example. Nowhere does it say that. In the guidelines it does say, but not in the, there's a disconnect between the guidelines and what the insurance companies have requirements. So everything else being equal, if money was not a problem, yes, definitely. The challenge is access, and it depends on where you are and how much, access to the drugs that you have. But I fully agree. Anything like that, in the first case that I showed, we would change drug to the biologic or a small molecule inhibitor like tofacitinib or upadacitinib. It all depends on the other domains that is affected.
Thank you, doctor. So I consider myself an ultrasound fan. So every patient who was referred to our service, we scan with the ultrasound each joint and testis. But my question is about what should we do with subclinical arthritis with enthesitis? Should we change our treatment with subclinical arthritis or enthesitis?
Right, and that's a good question. Do we change therapy if there is subclinical disease? At the moment, we don't have, the guidelines don't say that. There is actually a trial. It's called a prevention trial, but it's the PAMPA study, and I'll talk about it in the next lecture. They're trying to see if the treatment with guselkumab prevents that becoming more active. But at the moment, we don't have evidence to say that treating asymptomatic disease, subclinical disease, is going to prevent overt disease. We'll have trouble accessing it, but I would say is that once you're doing ultrasound, you're seeing these changes, you can explain to the patient and also keep the patient on close follow-up, right? Come back every, say, 6 months for a proper assessment, and when you see more active disease, maybe you can initiate therapy. There is research going on about prevention to say, should maybe, the current trial is with guselkumab, but just like in RA, there have been prevention trials with hydroxychloroquine, methotrexate. Some other drug could be something that could be used. But if there are other risk factors, if the patient is obese, if metabolic syndrome, if he's an athlete and is doing too much of physical activity, you could tailor your suggestions on better, healthier lifestyle from both extremes, right? So that you can prevent that progression. But it's a problem that we have, but we don't have a solution to that. But I would say close follow-up would be the answer for now.
Okay, the last question. I have one question for you, Dr. Chandran. You frequently to see in clinical practice patients with arthritis, but seronegative, rheumatoid factors. However, over the course of the disease, you realize that the patient probably have psoriatic arthritis, but what places of the skin do you recommend to explore for the physician in order to an early detection of skin lesions? Because sometimes this lesion can be subtle, mild.
Yes.
So which places of the skin or the body the physician should focus to detect these lesions early?
Yeah, so seronegative rheumatoid and psoriatic arthritis, polyarthritis is always a big problem, and they are conceptually very different diseases, but there is that overlap, and sometimes I was talking to Dr. Evans, John Adams from the UK 2 weeks ago, where he's an RA expert, the most difficult RA patients are the seronegative ones, and he wonders if it is actually a spondyloarthritis. And so to diagnose that kind of psoriatic arthritis, you've got to really look carefully at the skin. And where do we look for it? The research say that scalp psoriasis is some area to look for carefully. So look at the, and that's not easy, but we have to get our help from the dermatology colleagues. Scalp, and then the flexural regions, the natal cleft, so between the buttocks, to look there carefully, and then axilla, groin, under the breast, those are the areas which we generally don't examine because, from societal regions, but if you can explain the patient that, look carefully for it, and if you find a rash, get the dermatologist help look for it. And also nail disease, right? So nail and the flexural disease are the ones that are difficult to diagnose and may be best if the proper physical exam is not done. So those are the areas I would focus on.
Okay. Thank you, Dr. Chandran. Muchas gracias a todos. Creo que terminamos, ¿cierto? Muchas gracias a todos por su asistencia. El Dr. Chandran, el Dr. Wilson Bautista y obviamente a Pfizer por su amable invitación. Vamos a la plenaria, ¿no?